A warm good evening to all of you, to all the participants who choose to enter into this webinar, who choose to attend this webinar conducted by Milan. So, from the House of Milan, a warm good evening to all of you. I also wish and hope that you and your family are safe from this pandemic. My sincere thanks to each one of you, to all the doctors who are actually, warriors in white, who are saving the life of the patient and risking their own life in this pandemic. A sincere thanks on behalf of Milan. So today we have one of a very eminent professor with us, Dr. N. Arun. Sir, on behalf of Milan, I welcome you for and thank you to be a speaker and enlighten with your knowledge to all our participants. So a little introduction for Dr. Arun, though he doesn't require one, but he is a visiting faculty consultant in the Belroth Hospital and MGM Hospital in Chennai. He is a director in Chandra Gastro, Liver and Endoscopic Center. Dr. N. Arun has an area of interest in liver transplant, immunosuppression guidelines, and in plasmapheresis. Dr. N. Arun is also a life member of ISD, INASIL, and many other esteemed organizations. I'm highly obliged that Dr. Arun is speaking today for us and enlighten us with his knowledge. All yours, Dr. Arun. Thank you so much.
Thank you, sir, for a very brief introduction. And good afternoon, respected professors, senior consultants, and my dear friends. It's really a great pleasure for me to be here in this this terrible pandemic to share some knowledge about the management of complications of cirrhosis that we are frequently encountering in our day-to-day practice. I also would like to thank Milan Pharma who have given me an opportunity to be in this forum. So to enter into the discussion about the management of complications of cirrhosis, the management of cirrhotic related complications, to discuss briefly, to brush out the basic knowledge, what do you mean by cirrhosis? Nothing but a late stage of progressive hepatic fibrosis, which is characterized by distortion of the hepatic architecture and the formation of regenerative nodules. As you all know that generally consider once a cirrhosis is going to set in, it will be irreversible in its advanced stages. In earlier stages, specific treatment are there to improve the cause. And to discuss about the etiology, as we all know that the common scenario in India will be because of alcoholic liver, and B and C will be taking the next forum apart from that, and non-alcoholic fatty liver disease apart from West is still more common and more commonly rising in even India too. And natural history, to discuss briefly, any normal liver can go for a fatty and then can go for a chronic hepatitis, cirrhotic changes, hepatocellular carcinoma. Based upon the etiology, the time duration of presentation, and the mode of the changes into the chronic presentation will vary. And how to classify based upon classification of cirrhosis mainly by a compensated as well as a decompensated. The decompensated cirrhosis, once a patient develops evidence of portal hypertension as well as a full hepatocellular synthetic function if it is going down, which leads you to ascites, a varicose bleed, a non-obstructive jaundice, and followed by hepatic encephalopathy if it is going to set in. So one of the ways to see, this is a basic idea about the classification of cirrhosis, which based upon stage 1, 2, and 3, and 4. So if it is 1, the mortality is very low because that will not be any esophageal varices. If it is stage 2, it will be having evidence of varices, will be there with evidence of compensation. The mortality will be slightly high, will be up to 3.4% per year. And stage 3 will be having slightly more decomposition and with the evidence of formation of ascites. And stage 4, there will be evidence of GA bleed in which the mortality is very high with evidence of decompensation. As we all know that the commonest, more common complications will be encountering in the management of cirrhosis, and usually will be because of the portal hypertension. There will be varicose hemorrhage, ascites, HRS, and hepatopulmonary syndrome, and spontaneous bacterial peritonitis, hepatic NCAF, and rarely hepatocellular carcinoma, and portal vein thrombosis can also happen in the complications of cirrhosis. And today, my area of interest to disclose all the main key areas of hepatorenal syndrome, as well as a brief snapshot view of varicose hemorrhage, as well as in the management of refractory ascites. That is the main motive for me to discuss with you all in the management of complications of cirrhosis related issues. To discuss with you, to begin the main area of discussion, I'll be starting my area with this brief case snippet in which a 50-year-old male who presented to us with a nationalized cirrhosis with evidence of decompensation, and his MELD sodium is around 22, who is on frequent large volume paracentesis. So you will be knowing that if the patient presents, you will be frequently encountering. In many centers, every week they'll be doing paracentesis. In some centers, they'll be doing very less of around 1 liters, 2 liters of paracentesis. Some centers they'll be doing around 4 to 5 liters of paracentesis, and these things will be vary according to the center. But this patient is on large volume paracentesis, but even after that, the patient is going to be on diuretic with worsening of creatinine. We'll be frequently encountering the paracentesis. We couldn't able to titrate the dose of diuretic because his creatinine is going to worsen. And so this kind of issue, if you are going to face, how are you going to manage? So this patient's BP, if you're going to check, the BP is around 90/60 with pedal edema, and his baseline LFT and RFT will be minimally altered with a MELD sodium of approximately 22. How to proceed this patient, a brief process in the management as well as in the process of liver transplant workup. So if you're going to come to the discussion, the prime streamline will be because of any patient who is going to from a transition from compensated cirrhosis to decompensated cirrhosis usually occurs at the rate of around 5 to 7% per year, if you are going to look into that. So in case of compensated, in case of decompensated, that is stage 0, 1, and 2 will be compensated, and stage 3, 4, and 5 will be because of decompensation. So stage 3, the stiffness measurement, HVPG is a main indicator, and there will be a mild portal hypertension. So liver stiffness, if it is going for more than 15, and HVPG if it is going for more than 3 and 10, and will be having stage 0. And if the patient doesn't have any varices, but evidence of HVPG more than 10, there should be evidence of clinically significant portal hypertension, and stage 2 will also represent the same. And once a patient going for decompensation, the patient can go for evidence of bleeding, and stage 4 can go for decompensation, first non-bleeding decompensation with minimal organ failure or hepatic NCAF or any other thing. Stage 5 will be a second decomp, coexisting other system involvement can also happen, and the final end stage, the patient will be progressing to refractory ascites, protosystemic NCAF, jaundice, multiple infections, or renal and other organ dysfunctions, which will predispose to ACLF as well as to death of the patient. So briefly discussing this about the multi-stage model. So if you're going to look into that, any compensated to decompensated will be, as I discussed with you, it will be taking around 5 to 7% per year. So if the patient is asymptomatic, the median survival will be up to 12 years. And once the patient becomes symptomatic, once the patient enters into the state of decompensation, the survival rate will be only for 2 years. As we all know that as for the late decomposition, once a patient develops refractory ascites in ACLF, the patient's death is going to ensure for that. So briefly about the pathogenesis of ascites and portal hypertension, how is it going to set in? As we all know that the liver, once a patient develops cirrhosis, the liver architecture is going to completely disrupted, and the portal pressure is going to get high, which leads to portal hypertension. Once a portal hypertension develops, there will be splanchnic vasodilatation and systemic vasoconstriction will be there. Once a systemic vasoconstriction, what's going to happen? Multiple organ systems is going to involve. So splanchnic vasodilation, which leads to increase in splanchnic capillary pressure, which will predispose to ascites. Formation of ascites is mainly because of the reduction of oncotic and increased hydrostatic pressure. And once vasodilation process starts in, there will be multiple neurotransmitters. The main one, the vasodilators will be releasing because of nitric oxide, so which will predispose to mesenteric vascularity will be impaired and other things, and the patient can go for the activation of the vasoconstrictor and many natriuretic factors, which will predispose to formation of ascites and other major complications. To discuss briefly about the pathogenesis of portal hypertension. So if you're going to see this picture, not all the patient with evidence of compensation or decompensation will be having evidence of worsening of renal functions or worsening of presenting with the diuretic refractory ascites. If you're going to look into that, initial presentation will be because of ascites, and as day goes on, the patient can go for, once the patient develops splanchnic vasodilatation, which is non-responding, can go for diuretic refractory, and once the patient develops renal vasoconstriction at end phase, hepatorenal syndrome can set in. As we all know that if the patient going to develop hepatorenal syndrome, always in our scenario, if you're going to get a minimal rise in creatinine with a minimal decomposition, don't immediately come to the conclusion that the patient is having hepatorenal syndrome, because a hepatorenal syndrome is usually a late onset of presentation, and it will be once a patient develops severe decompensation, usually it occurs as a late mode of presentation because of splanchnic vasodilatation as well as a severe renal vasoconstriction. So this is called the natural history of ascitic formation. So once a patient develops portal hypertension, no ascites, which leads to uncomplicated and refractory, and finally HRS is going to set in if the patient HVPG is going to be more than 10 millimeter with extreme vasodilatation. So briefly about the snapshot outlook view about what is going to be happening, how are you going to approach a patient with ascites? As we all know that anything, first thing we need to do ascitic chart, and we need to calculate the SAG for the patient. The SAG should be more than 1.1 or less than 1.1. If it is going to be more than 1.1, that indicates significant portal hypertension. It's a clue. And then if the patient is having high SAG ascites, we need to look for the treatable causes. If the patient is alcoholic, eliminate the cause. If the patient is having any other viral etiology, always look for the viral events to prevent progression to hepatocellular carcinoma and other major factors. And always look for the precipitating factors like any dietary indiscretion, diuretic non-compliance, GA bleed, and hepatocellular carcinoma without a PVT, and any other drug abuse, NSAIDs, for example. And always, first thing when you're going to manage a patient with ascites, the salt restriction is the main modality. Make sure that the patient's sodium intake should be less than 2,000 milligrams or 5.2 grams of salt per day, which is equivalent to 88 millimoles per day. And low salt diet alone, it is going to eliminate the ascites in approximately for 10% of patients. So if you're going to put the patient on diuretic, multiple modalities, first line of therapy will always be preferred by spironolactone, but you're going to combine two diuretics, either spironolactone with furosemide or with torsemide. So what is the reason? Because if you're going to combine two diuretics, that will be a greater and faster effect on urinary sodium excretion at different sites in the tubules, and less frequent development of hyperkalemia, because loop diuretic is going to counteract the potassium sparing diuretic of the anti-aldosteronic drug. So the common adverse effects are well known, spinal gynecomastia and other things will be happening. And we can suppose we can start by furosemide of 40 and spironolactone of 100 milligrams once in the morning, and slowly. And other drugs, like suppose if the patient develops gynecomastia, we can go for amiloride. But if ineffective diuresis, then we can slowly step up the drug. And when you're going to treat this patient for ascites, we always need to calculate the urinary sodium excretion. We need to target a urinary sodium excretion of more than 78 millimoles per day, which means if the patient, it's a spot urine sodium, which is almost equivalent to the spot urine sodium potassium ratio of more than 1. So it indicates the excretion will be of urinary sodium will be more than 78 millimoles. Suppose if there is a negative balance and with the weight loss of only 0.5 kilograms per day, there will be more in patients with peripheral edema. Then there is an indicator for you to increase the dose of diuretic after 3 days if there is no further response. So basically about the definition of refractory ascites is the main area to discuss right now, that if ascites cannot be mobilized or the early recurrence after large volume paralysis, that means after a minimum volume of around 5 liters of fluid, even after that, if you are going to remove and if it is going to recur early, that is indicator for refractory ascites. And if you are going to classify that, it is because of diuretic resistant and diuretic intractable. Diuretic resistant is even after the adequate salt restriction and sodium restriction, if the patient doesn't going to improve, it's diuretic resistant. And if the patient going to develop any complications because of the diuretic, and it's preclude for you to stop the dose of diuretics, so that will lead to diuretic intractable ascites. So this is a basic diagnostic criteria as per AA's statement. So if the patient is, if you want to consider the patient for refractory ascites, there should be at least a high dose of diuretics for a period of 160 and 400 milligrams of spironolactone, 160 of fluoxamine to be given for at least a week, and an salt restriction diet of less than 90 millimoles per day. If there is lack of response, means the weight loss is not going to come down of less than zero point 0.8 kg over 4 days, and unit sodium output is going to be less than the sodium intake, means it shows evidence of lack of response. And recurrence of ascites, early recurrence means which it can be a recidivant ascites, or early recurrence ascites, mainly because of if the patient develops grade 2 or 3 within 4 weeks of initial mobilization of ascites. So early ascitic recurrence, which means the patient still need a further aggressive management. And once the patient develops diuretic induced complications like hepatic N curve, renal impairment in the form of creatinine, it is going to be more than 1.5 to 2, and hyponatremia, if the patient develops hyponatremia-related complications, or once the patient develops hypo or hypokalemia, incapacitating muscle cramps. These are all the criteria because of diuretic induced complications will also be considered in the management of refractory ascites. So, as per the refractory ascites AACD statement, sodium restriction as well as high dose of diuretic, that's what been discussed. And failure of diuretic therapy may be manifested by the unit sodium excretion will be less than 78 millimoles per day, and the patient develops complications of high creatinine and serum sodium very low, less than 120. Serum potassium, which is going to be more than 6 millimoles. Then there is evidence of refractory ascites. So once the patient been documented with refractory ascites, the modality of treatment differs. There will be a medical line of management, and we can go for large volume paracentesis, and finally we can go for TIPS or liver transplant, and other new modalities of treatment is still available. And basically, to discuss about the initial treatment, so what is the initial treatment for the patient with refractory ascites? Always we need to eliminate the cause and eliminate the harmful medication. Suppose if the patient is on ACA, ARBs, and NSAIDs, it should be stopped aggressively. And next to that, we always supposed to talk. We need to see why the patient is not responding, why the patient's creatinine is worsening, even if the patient is diuretic. So we need to target the mean arterial pressure. So if the mean arterial pressure, if it is going to be more than 82 millimeter of mercury, there is a 70% chance of surviving for more than 2 years. And if it is going to be less than 82 millimeter of mercury, the 2 years survival is definitely going to come down. So the role of NSAIDs inhibits the synthesis of renal prostaglandins, so which leads to renal vasoconstriction, and also the possibility of worsening of renal failure will ensure. That's the reason we should stop all the major harmful medications. So next to that, the step 2, apart from that, the low sodium diet and diuretics has to be followed. The low sodium diet is nothing but 2000 milligrams per day and no added salt. And diuretics should be discontinued once a patient develops worsened complications like hepatic N curve or renal impairment or severe electrolyte disturbances. So diuretics continued only when the urinary sodium, if it is going to be more than 30 millimoles per day. Regarding the process of management of beta blockers always been wondering that, so if the patient develops refractory ascites, we need to discontinue beta blockers. But my experience, what we are thinking about, we can think at the lower dose of propranolol, around 20 to 40 milligrams, even 80 to 160 milligram lower propranolol dose can be considered, rather than thinking in terms of carvedilol, because carvedilol is also having alpha adrenergic activity. So as per the Bavina's statement, if you're going to use beta blockers, you should make sure that the systolic BP, if it is less than 90, if the serum creatinine, if it is more than 1.5, or hyponatremia, if the patient develops less than 130 of sodium, then it's not, I mean, the dose of beta blockers should be reduced or even should be discontinued at this point of time. So regarding oral midodrine, that's the main area for me to discuss right now. So midodrine is a oral vasopressor. It increases blood pressure in advanced cirrhosis, which leads to resulting in improved renal perfusion. So what we are going to do, we can use in patients with hypotension and a diuretic resistant ascites. So if you're going to use midodrine, so first thing you can start at around 5 milligrams orally, and slowly we can titrate the dose as per the map. So briefly about the discussion of midodrine, you all know that the metabolic product will be at less glyme midodrine. The plasma concentration will be approximately 1 hour, and for midodrine will be approximately half an hour, and it will be predominantly be metabolized in the liver, and it will be eliminated in the urine. So this is a brief. So once the midodrine being converted to the active metabolite, and it forms alpha-1 adrenergic, and because it's being involved in the pathway of alpha receptor agonist, so what is going to happen? It will predispose to the increase in vascular tone, and it will elevate the BP. So once BP is going to come high, so the splanchnic vasoconstriction is going to happen. The predominant pathology in cirrhotic patients will be because of splanchnic vasodilatation, and here the splanchnic vasoconstriction is going to happen, which will predispose to improved systemic circulation and improve renal function and increase sodium and water excretion. So thereby your ascites will come down. So as I discussed with you, some centers being tried with 2.5 milligrams, but for certain patients, even if the patient's thin build, I can try 2.5 milligrams of dose, and slowly I can titrate the dose up to 5, and slowly we can increase the dose maximum of around 17.5 milligrams twice daily. So midodrine must be taken during the day. The administered interval should be 3 to 4 hours immediately after rising in the morning, at midday, and the evening, and at least 4 hours before bedtime to prevent the risk of supine hypertension. So this is one wonderful study from PGI by Professor Virendra sir, and what they have been done in 40 cirrhotic patients for midodrine with the standard medical therapy they have been tried. In this study, the midodrine has been taken around 7.5 milligrams twice daily. But what do you mean by the standard medical therapy? That if you are going to adhere with the low sodium diet, and if the patient is going to be on adequate treatment with diuretics, and even then if the patient is going to be on large volume paracentesis, that means the removal of more than 5 liters with evidence of albumin support. So with the standard line of treatment along with midodrine support, there will be evidence of improvement of ascites even in refractory ascites. So ASLD recommendations, oral midodrine has been shown to improve clinical outcomes and survival in patients with refractory ascites. So in this study, they haven't used midodrine around 7.5 as I discussed with you, and can be added to diuretics to increase blood pressure, and it will increase the urine volume and urine sodium. And the main target, if you're going to use midodrine, we need to increase the mean arterial pressure for us to enhance the survival. So there are the various studies being done in the usage of midodrine. Among the brief discussion about suppose if you are going to use midodrine, that has been discussed mainly in non-azotemic cirrhotic patients. In this study, if you are going to use that for 7 days, there will be improvement in the systemic hemodynamics, and sodium excretion will be there in the patient who are non-azotemic cirrhosis with or without ascitic presentation. So always you need to prefer, if the patient doesn't develop evidence of worsening of acute kidney injury or HRS to develop before that. If the patient is having only evidence of refractory ascites, and in the non-azotemic patients, we can try midodrine for a period of 7 days. Where in this study, they have been shown that the systemic hemodynamics and sodium excretion has been significantly improved. So in this study, what they have mentioned about in the first 3-hour period of the midodrine administration, they have been taking a significant increase in mean arterial pressure, a systemic vascular resistance, and a decrease in heart rate. The cardiac output is going to come down, and changes of MAP and heart rate were significant during this 3rd period. So which is definitely going to improve the splanchnic vasodilatation and other causes. So administration of midodrine in this study was shown to be a marker. So if you're going to look for the decrease, and what are the hormonal effects? If you're going to look for the hormonal measurements, the renal function, and the renal hemodynamics in patients without HRS, in this study they have been taken into account. So if you're going to administer midodrine, so what is going to happen? The plasma renin activity, because plasma renin, as we all know, that we need to measure the patient in refractory ascites after LBP. If the patient develops paracentesis induced circulatory dysfunction, PICD, then the plasma renin measurement will be taken into account, and serum nitric oxide and the plasma levels of ADH also. So there will be a decrease of all those things, but no changes have been observed in the plasma level of ANP or plasma aldosterone levels. So in refractory ascites management, if you're going to combine midodrine with octreotide, what's the response? So can reduce plasma renin activity, but midodrine alone can reduce PRA and increase GFR more potently than octreotide. So octreotide not to be given alone. So midodrine and octreotide can be combined, but reduce plasma renin activity. The midodrine role is slightly high. So in this study, they have used midodrine along with clonidine. So if you're going to along with midodrine and clonidine, or both plus standard medical therapy. So if you're going to give midodrine at around 7.5 milligrams 8th hourly, or clonidine at around 0.1 milligrams 12th hourly, so what is the response? So midodrine and a combination of midodrine and clonidine plus standard medical therapy will be always superior to standard medical therapy alone for the control of ascites. So no superiority of combination or midodrine alone being documented as per Singh et al. In 2013. So what's the role of 12-VAP10? So if you're going to reach the V2 receptor antagonist, VAP10, so if you're going to combine midodrine and 12-VAP10, so there will be rapidly controls ascites as compared to midodrine or 12-VAP10 alone. So 12-VAP10 not supposed to use alone. We can combine with midodrine. If you're going to see in this study, standard medical therapy with the combination at 3 months, there is a reasonable improvement. So this is a V2 receptor regarding VAP10. It's nothing but V2 receptor antagonist, which predominantly acts on the distal tubule of the kidney to increase the solid free water excretion. So we have been studied in 110 cirrhotic patients with ascites, comparing the efficacy of cetabaptan with the placebo for better control of ascites by Gaines et al. So many studies have been happening for the role of VAP10s being considered in the management of refractory ascites. So in this study, in patients with refractory ascites, if the patient is at month 1, month 3, and month 6, how does it going to eliminate whether the patient is going for complete response or a partial response or no response? So what do you mean by complete response? Which means the ascites has been completely eliminated, and the partial response means the presence of ascites but not requiring paracentesis, and the absence of response means the persistence of ascites which requires frequent paracentesis. So if you're going to assess that at month 1, 2, 3, there will be reasonable response in patients with midodrine with refractory ascites. So the main potential role for midodrine, it will make the mean arterial pressure to go high, increase the mean arterial pressure. That is the main modality for midodrine to alpha agonist to act. And next to that, cardiac output is going to get decreased, and systemic vascular resistance will be increased, and urine output and urinary sodium is also going to high, and plasma renin activity will be decreased to prevent PICD, and no renal or hepatic dysfunction has been proved. So there are some trials for rifaximin with midodrine, but combined therapy, there will be minimal improved clinical outcome. So we can try rifaximin also along with midodrine in the management of refractory ascites. Rifaximin and midodrine added to diuretics in difficult to treat ascites improve systemic and renal hemodynamics and short-term survival, and should be included in the management of these patients. So what is the role of combined therapy with albumin? So we suppose for the prevention of patients with cirrhosis awaiting liver transplant. It's a wonderful study. So if you're going to combine albumin in patients with refractory ascites undergoing large volume paralysis, suppose if you are going to give midodrine, you should give for a slightly more duration than a shorter duration of period to improve the renal perfusion as well as the sodium excretion. So if you're going to prescribe midodrine, don't always go for a very short duration. Try to increase the duration of midodrine to improve renal perfusion as well as sodium excretion. To highlight about the points of midodrine, the circulatory dysfunction is a key pathogenic factor. Improvement in circulatory function may prevent complications of cirrhosis. So midodrine plus albumin decreased renin and aldosterone levels. So our midodrine plus albumin did not prevent the complications or improves survival. So regarding the outcome, midodrine is non-inferior to albumin infusion in terms of maintaining the renal function, serum sodium, and 24 hours urinary sodium excretion, and no difference in mortality between groups. And long duration midodrine intake can be more useful than a shorter duration intake in terms of improvement of renal perfusion and sodium excretion. So we always prefer midodrine to be given at a longer duration than for a shorter duration of period. So other options of treatment for refractory ascites, as we all know that LVP, TIPS, and liver transplant to be considered. Large volume paracentesis, if you are going to do around 5 liters of fluid, if you are going to remove, for every liter, we need to transfuse the patient with 6 to 8 grams of albumin. Support has to be done. And if you, for example, if you're going to tap the patient 5 liters, so we need to supplement the patient around 20 to 30 grams of albumin. Support has to be done. So like that, we need to involve in the management process. So always we need to take care of the sodium excretion. Suppose in a patient, if you're going to do a 10-liter paracentesis, which means it will remove serum, it will remove the serum sodium approximately 1,300 millimoles. So see, that's the main thing. So if you're going to do around 10 liters, it will remove the retained sodium in patients with no sodium excretion. So our target, the sodium excretion has to be good, and spot urine sodium potassium ratio should be more than 1, indicate a 24-hour sodium excretion will always be more than 78 millimoles per liter in the management process. So if you're going to give albumin along with that, as I discussed with you, albumin infusion during or shortly, we need to give either during or shortly after parasynthesis. And terlipressin also can be given intravenously on 1 milligram at onset of parasynthesis, and 1 milligram at 8 hours, and 1 milligram at 16 hours. And midodrine may be as effective as albumin. So terlipressin and midodrine also can be combined in the management of refractory ascites and serial parasynthesis. The complications like protein depletion, which will further aggravate malnutrition and predisposes to infection and other things. So this is what is answer trial. And in this trial, if you're going to administer human albumin to your patients, approximately 40 grams twice daily for a longer duration of time. So if you're going to give albumin 40 grams, which means around 2 bottles twice weekly for 2 weeks, and then 40 grams weekly for up to 18 months of therapy, the improvement of the patient will be definitely high. The possibility of hyponatremic episodes is going to come down, and the ascites is definitely going to improve. To discuss something about briefly in the management of PICD, parasynthesis induced circulatory dysfunction, will approximately occurs in the patient with 18 to 34. Suppose if the patient doing a large volume parasynthesis, there is high possibility for this PICD to anticipate. And next to that, what is the reason for that? Because if the patient develops hypovolemia, and if there is increased aldosterone and ADH activity, and decrease in mean arterial pressure and systemic vascular resistance, eventually, which will lead to renal perfusion, and impaired renal perfusion and renal failure is going to set in. So PICD is one of the dreadful complications. So maximum it can occur after 6 days of parasynthesis. It's clinically silent and may not be fully reversible. So there can be a rapid recurrence of ascitic fluid, renal failure, hyponatremia, and overall survival is going to come down. So once a patient develops PICD, there is a role of terlipressin with albumin. Terlipressin versus albumin can be given. So terlipressin and albumin prevents PICD in this patient. If you're going to look into the study, so terlipressin also may be as effective as intravenous albumin in prevention of PICD. And the role of midodrine. So midodrine in this study, it has been proven midodrine, if you are going to give 12.5, if you are going to look at the dose what they've been administered in this study, they have been using around 12.5 milligrams 3 times per day over 2 days, or albumin at around 8 grams per liter of removed ascites if you are going to do. And it shows that PICD developed in approximately 60% of the patients in the midodrine group, and only in 31% in the albumin group. So midodrine in this study has been not as effective as albumin in the management of PICD. And so PICD, once a patient develops parasynthesis induced circulatory dysfunction, so if you're going to compare albumin with dextran and polygylene, so if you're seeing that, so without volume expansion, the PICD response will be there around 75%, and 40 to 50 will be with dextran and polygylene, and 15% only with albumin support. So albumin definitely going to reduce the severity. So to discuss about the other modalities of treatment, one is TIPS. What is this TIPS? Nothing but transjugular intrahepatic portosystemic shunt. So in which we are going to aim at creating a shunt between the two major systems. One is because of the portal, and one other because of the hepatic system and hepatic venous system. So if you are going to use TIPS, and when you're considering a patient who is having a MELD, approximately less than 15 and other thing, and if you're going to be involved in the management of ascites, it's better to go for TIPS at the earlier onset rather than to wait for TIPS if the patient is affordable, and if the patient is affordable, to prevent other major complications. If possible, we can go for TIPS rather than considering the patient for large volume parasynthesis. But one complication we need to ensure that hepatic NCAF will always can occur in the patients. Around 25% of the patients can anticipate, and if you're going to go for TIPS, then we have various it's covered and batch stents are available if you're going for TIPS. And we always initially been chosen the size of around 10 millimeters. Now it's special size of 8 millimeters, and some studies also they have mentioned even if you are going for 6 millimeters, that is also can be used. So MELD was originally developed to predict survival after TIPS incision. That was the main indicator for MELD development. So this is basically the outline of TIPS. So another management about refractory acid is that is alpha pump, which is currently not available in India and it's very expensive. So what you're going to do in this, if you're going to place a battery subcutaneously, so what you're going to do, your fluid is there, your acid is fluid from the peritoneal cavity, you're going to transmit to the urinary bladder. So what is going to happen? It facilitates the removal of fluid by urination. So in this, there are so many inconveniences there because the battery system will be less, around 20 minutes twice a day you need charge, and significant reduction in alpha pump, but it shows a significant reduction in the frequency of large volume paracentesis. So if possible, we can use alpha pump, but currently there is no much of data in India. So in this study by Bella et al., what have we mentioned about the pump system? Around 9 centers are followed up for a period of 6 months. So what they mentioned that the large volume, there will be a significant reduction of large volume paracentesis. So there is Plurex can be used. To discuss briefly about that. And how do you, this finally, before concluding about the management of refractory ascites, and so what is the approach to management is cirrhosis. If the patient is having cirrhosis with ascites, even with the routine measures like standard medical treatment, if the patient is not going to respond, we need to stop the dietary study, whether the patient is being adhering to the low salt diet or whether any precipitating factors like alcohol, any coexisting viral infections or any of the NSAIDs, or treat the etiology, or the patient develops hepatocellular carcinoma, or we need to stop the patient on beta blockers. So many things to be considered in the management, and followed by anyhow the patient develops refractory acid. We need to do a diagnostic tab, because always we should not eliminate the SPP. Spontaneous bacterial peritonitis will always coexist with that, and we should not miss out even tuberculosis, and 24-hour urine sodium by potassium, spot sodium potassium has to be calculated. And sometimes we may use LVP, large volume paracetamol with albumin support. The role of midodrine is questionable, but it can try if the patient is having low MAP to raise the MAP. Our target should be around 5 to 10 millimeter mercury above the baseline. And we can also consider tips. If the patient is affordable for tips, we need to consider tips as an early answer, but only criteria should be the MEL around 14 to 15. Once the patient crosses the MEL more than 20, and the possibility of tips and other complications survival will be definitely a questionable issue. And we can, if all these things is not working out, we can consider the patient for long-term albumin support, as what we have been discussed in answer trial, along with the patient finally can anyhow go for, because the liver needs to regenerate. The process of liver failure is going to ensure for sure. We need to make sure that the patient is going for transplant as early as possible. And to discuss something about the next area to discuss is hepatorenal syndrome. In this, there are multiple diagnostic criteria for hepatorenal syndrome. One is by KDIGO, Akin, so many criteria are there. But right now, the traditional diagnostic criteria, always if you want to suspect hepatorenal syndrome, it is nothing but it is a phenotypic renal dysfunction in a patient with cirrhosis and ascites. So usually, as I discussed with you in the initial slide, HRS you should not consider for any patient with the initial presentation, but it will be a severe ascites going for a long time, and once the patient develops severe decompensation, the patient can develop HRS. To ensure the criteria of HRS, there should be cirrhotic with ascites, and creatinine should be more than 1.5, and the initial definition of type 1 and type 2 HRS, which is not being much of use nowadays, and this definition has been changed completely right now. But even then, to brush up what is type 1, if it is more than 2.5 milligrams per deciliter and is a worsening of creatinine in a period of less than 2 weeks, and there should not be evidence of shock and no evidence of any treatment of nephrotoxic, and other parenchymal kidney disease should not be there if you want to diagnose. And even after the stopping of the diuretic, there will not be any improvement of creatinine, at least 2 days duration of diuretics withdrawal. And even if you're going to place a patient with albumin around 1 grams per kg body weight, so with all this trial, with all these things, if you are going to consider if it is going to be proven, there is evidence of HRS. So this is a revised statement about the IAC International Ascitic Club criteria on the diagnosis of AKI, acute kidney injury in cirrhosis. Now the definition is mainly based upon AKI is there or not. So what is that? So baseline serum creatinine concentration. So in this revised IAC, they're mainly focusing on the staging. So what is the staging? If the patient is present stage 1, 2, and 3. If the serum concentration, if it is more than 1.5 to 2 times the upper limit of normal, and if the serum creatinine concentration is more than 2 times of the upper limit of normal, it's stage 2, and if the creatinine concentration is more than 3 times the upper limit of normal, it's stage 3. So in this, we need to assess whether the patient is having response to treatment is done, no regression of AKI, Whether it's a partial response means a regression of AKI with decrease in serum creatinine to value more than 0.3 milligram per deciliter. And if it is a complete response, there will be a decrease in serum creatinine to less than 0.3 milligrams, more than 0.3 milligrams per deciliter in less than 48 hours period, or 50% increase from the baseline. So to conclude, so if you want to remember something about the newer classification for HRS, this one is right now being used. The old classification is HRS1 and HRS2. Right now, what we have been classifying as HRS acute kidney injury and HRS non-AKI. So if you are going to subdivide HRS non-AKI, it could be because of HRS acute kidney disease, it could be HRS CKD. So what is going to happen in HRS AKI? So here the three major parameters, one is creatinine, if it is going to be more than 0.3, and urine output if it is going to be less than 0.5 ml per kg, and the serum creatinine baseline value if it is going to be more than 50% of the upper limit from normal. And to define HRS AKD, it should be acute kidney disease, means the damage condition mean EGFR if it is going to be less than 160 ml per min per meter square, and percent increase of serum creatinine within 3 months of the baseline value. So if you are going to be more than 3 months with the EGFR of around less than 60 ml per min, which means the patient is going for HRS chronic kidney disease. If it is for more than 3, it's for chronic, and if it is for less than 3, it's for acute. So new definition will be mainly based on HRS AKI and HRS non-AKI, and the entire management process based upon this. But the one questionable thing, our initial management protocol as per the various trials being devised only by HRS1 and HRS2 criteria. But HRS AKI and HRS non-AKI, the newer definition, the management protocol accordingly is yet to be published more. To discuss about the pathophysiology, so what is going to happen? So once the patient develops cirrhotic, there will be release of splankling vasodilatation is going to set in, as I discussed with you. So what is going to happen? The nitric oxide is going to release, so which is going to reduce the effective circulating volume, and the patient can go for, it will be acting on, once the effective circulating volume is going to come down, it will be acting on multiple systems. It can act on kidney, it can act on brain, it can act on baroreceptors. The multiple things will be activated. Once the renal vessels being involved, the RAS system, the renin-angiotensin system, is going to activate, which will predispose to increase renal vasoconstriction because of splankling vasodilatation, renal vasoconstriction. So there will be a renal sodium retention, and it could not be eliminated. A solid free water and hyponatremia and reduction of GFR is going to set in. And finally, the cardiac dysfunction and other things, cardiac tachycardia, and because of the vasopressin release, other complications in the brain, which is going to develop in the late phase of HRS. So to discuss about the mechanism of renal injury potentially involved in HRS AKI, one is because of the renal hypoperfusion, and the next one is because of the direct tubular damage, so and because of the microvascular dysfunction. This entire picture comprises about the various pathophysiology which is being involved in the process of HRS AKI to develop. So this new pathophysiological hypothesis what been discussed about acute decomposition and development of organ dysfunction in cirrhosis. So if you're going to look here, once a patient develops portal hypertension, what is going to happen? There will be lipo-oligosaccharide activation, bacterial translocations process is going to be initiated, PAMP release will be more, PAMP and DAMP activation will be there, the innate immunity activation of the innate immunity will be there, which will lead to a release of reactive oxygen species and pro-inflammatory cytokines, and splanchnic and pulmonary artery vasodilatation and inadequate cardiac output is going to set in. So once the patient is going to develop splanchnic and pulmonary artery vasodilatation, what is going to happen? The multiple systems is going to involve, all the system is going to downregulate, which will predispose to renal dysfunction, hepatic NKF, hepatopulmonary syndrome, or renal dysfunction. Everything is going to happen because of the bacterial translocation, PAMP and DAMP release process. So to discuss about the management, so always in the management of HRS, we need to take the basic measures has to be taken, the drug therapy, and any of the non-pharmacological mode of therapy, and the preventive measures has to be considered. So what is the basic measures? We need to eliminate the triggers. If you have suppose if the patient is type 1 HRS, we need to require hospitalization, but type 2 HRS can be managed even on outpatient basis. And if the patient, we need to eliminate the causes, eliminate the triggers. If the patient is having any underlying diuretics for a longer dose, we need to stop it. And if 5 liters of acidic fluid is going to be removed, then albumin definitely is supposed to be used, and low salt diet should be reinforced. and major interventions like pharmacological vasoconstrictors and tips and RRT and liver transplant can be considered in the management of hepatorenal syndrome. So the basic measures, as I discussed with you, eliminate the triggers, like we need to stop diuretics, beta blockers, and if the patient is having diarrhea, stop lactose. And once the patients are lost to blood, you need to go for blood transfusion. When you're going for blood transfusion, you need to take for TEG and ROTAM. That is the main thing. If you're going to use FFP, or whether the patient is going to be on cryo, based upon your clinical presentation and based upon the TEG and ROTAM values, we can calculate nowadays. But TEG and ROTAM values could not be available in most of the centers. But our target should be aim in focusing that. A septic workup has to be done, and empirical antibiotic therapy can be initiated in the management of HRS. So what is the pharmacological drugs being available? Mainly by the vasoconstrictor, systemic vasoconstrictor like chalipressine, octreotide, and midodrine being used nowadays. But what happened to the renal vasodilators like dopamine, phenyldopamin, and prostaglandin? Because this is not being used nowadays because of lack of benefit in the renal vasodilatation in HRS. Use of renal because of that, it has been largely abandoned. And what is the role of systemic vasoconstrictors? They rely on the assumption that interrupting this splanchnic vasodilatation will subsequently relieve the intense renal vasoconstriction. So systemic vasoconstrictors like Turley, Octreo, midodrine, and norepinephrine definitely having a potential role in the management of hepatorenal syndrome. So the first line of drug will always be a terlipressin in the management of HRS, and second line will be because of NORAD. And if you're going to combine octreotide with albumin, doesn't much of effective in the management of HRS. And oral midodrine monotherapy will not be of much of use in type 1 HRS, and type 2 there will be a minimal improvement of renal function, a minimal improvement in systemic hemodynamics, but the renal function is not going to improve much. So if the patient is having type 1 or HRS AKI, the role of midodrine is questionable, and it's not recommended to use in HRS AKI type 1. And so midodrine plus octreotide plus albumin, if you're going to use, that shows some significant improvement in renal function when you are going to combine this therapy. And vasopressin analogs, it's still having a questionable issue in the role of management of HRS. And tips, if the possibility, may be used in a select group of patients. And combination therapy definitely will be having an improvement with vasoconstrictor therapy and tips insertion in the neurohumoral as well as the hemodynamic changes in HRS management. So if you're going to see this flow chart, so if you're going to, the main line of modality, either terlipressin plus albumin in the management of HRS. Next to that will be a noradrenaline and albumin. And the third one will be octreotide, midodrine, and albumin. And based upon the response, we need to calculate whether there is no response to the treatment, whether there is partial response, which means a regression of AKI with reduction of to more than 0.3 milligrams per deciliter about the baseline creatinine. And the complete response means the creatinine level will be within 0.3 milligrams of the baseline value. So what is terlipressin? What is its role? Because it binds to it's a strong vasoconstrictor. It will be acting on multiple receptors. One is V1H and another one is V2, and other things will be involved in the management of terlipressin. And suppose it will be binding to the V1 receptor of the vascular smooth muscle, which will cause a vasoconstriction in both the systemic and the splanchnic, and dilates the intrahepatic vessels, thereby reducing the intrahepatic resistance to portal flow, which will cause a reduction of portal pressure, which has a direct beneficial effect on renal function in cirrhosis. But if you are going to use terlipressin for a longer duration, and sometimes it will activate the V2 receptors also, which will make sure that the sodium retention can go high. So that is one more thing in terlipressin. Sometimes the patient can develop a retention of sodium, and other complications will be there if the patient is going to be on terlipressin. So how do you assess your response to terlipressin? Always you should remember that a certain your MAP should be the target. The MAP has to improve by more than 5 to 10 millimeter of mercury on day 3. And you should not use the beneficial effect as terlipressin will be a questionable one if the patient's serum creatinine, if it is going to be more than 5. Our target should be the creatinine should be less than 5. And once the creatinine value is going to get high and high, there is no point in using terlipressin. And serum bilirubin it's to be around less than 10 milligrams per deciliter, and childbirth should be, that should be a low urinary NGAL levels has to be ensured. So, in you're going to initiate the treatment with terlipressin, make sure that the bilirubin should be less and the MAP target has to be attained, and the bilirubin, baseline serum creatinine should be less than 5 milligrams per deciliter. And whether to use terlipressin as a continuous infusion or as a bolus dose, so always a continuous infusion is more preferred rather than, because if you're going to use continuously either terlipressin or norepinephrine, the beneficial effects in reduction of portal pressure, in reduction of normalized planking vascularization will be definitely high rather than using as a bolus dose. Regarding norepinephrine, it doesn't, even then the cost issues have been slightly, when compared to Terli, will be definitely low, but there are certain cardiac effects will be there. And apart from that, in multiple trials, the noradrenaline even has been proven if you're going to use at around 0.5 mg per hour, followed by if you're going to step at around 3 mg per hour, there will be improvement in renal function in case of HRS. So in this study, Duex et al., what they mentioned, if you're going to use norepinephrine at a mean dose of around 0.8 milligrams per hour until reversal of HRS or for a maximum of 15 days, albumin was administered along with that. So reversal was observed in around 10 of 12 patients after a median of 7 days. So norepinephrine has definite potential role in the management of HRS. And next to that, what is the role of midodrine? In type 1, in HRS AKA, the midodrine role is a questionable thing. But as per Cavalli et al., when you're going to, what they've been shown that terlipressin plus albumin, what they've been mentioned is far superior than combination of midodrine, octreotide, and albumin. So what they've been mentioned, see, if you're going to use terli and albumin, the response rate will be approximately 70.4, which is being significantly better than the combination of mido, octreo, and albumin in the management of HRS, which will be showing only approximately 28.6%. So they were associated with improvement in kidney function survival, but compared with no treatment arm. So these are the basic doses about the terlipressin. As we have discussed about, we can go up to initially by 0.5 and maximum dose by 2 milligrams every 4 to 6 hours. We can maximum duration up to 14 days, and continuous infusion start by 2 milligrams per day, and we can go up to 12 milligrams. And norepinephrine start by 0.5 to 3 mg per hour, and always target the mean artery pressure should be around approximately 10 millimeter of mercury above the baseline. And if you are going to use a combination therapy, you can go for midodrine. In my experience, what we have been trying in our centers, when you're going for midodrine, we'll be starting at around 5 milligrams TDS daily. But as per, we can even step up or step down. We can go up to 12.5, and some patients we can go up to 17.52. But usually we have been preferred either by 7.5 to 10, and we will be titrating the patient as per the clinic, and along with low salt and diuretic response has to be considered. And midodrine we can give even up to a period of 3 to 6 months, and sometimes even up to years. So regarding octreotide, we can give 100 micrograms subcutaneously and followed by 12.5 micrograms 3 times daily, and 100 mics subcutaneously followed by continuous infusion of around 50 mics per hour also can be used if you are going to use octreotide. So this is the entire scenario, what's happening, the 30-day and 90-day survival following renal transplant for HRS by treatment modality, what they mentioned. So if you're going to use vasoconstrictor plus TIPS therapy, the 30-day survival and 90-day survival is definitely going to be very high when compared to either the monotherapy or octreotide or midodrine alone. And this is what about the discussion of hepatorenal syndrome. And before concluding, a brief snapshot view what is happening in the management of acute varicose bleed. So if you're going to discuss about acute varicose bleed, we need to target the airway breathing and circulation, and we need to assess whether the patient, because of varicose or non-varicose focus, and take care of the PRBC transfusion strategy. And if you're going to use FFP, but always you should be very cautious, because if the patient is having evidence of portal hypertension, if you are going to use unnecessary overload of FFP, which will further worsen the portal pressure, which will make the portal bleed to worsen further. So sometimes what you're supposed to do in this case scenario, ideally a PRBC transfusion policy can be considered, and at around 7 grams, the hemoglobin has to be maintained. Another vasoconstrictor, the terlipressin is the first line of choice, and octreotide, somatostatin also can be considered. And antibiotic prophylaxis can be enhanced, and we need to categorize the patient whether the patient is not in high risk like child A or child B cirrhotic, or if the patient is in child C cirrhotic process in the management of acute variceal bleed. So, this is about the outline of drugs what we use in the management of acute variceal bleed. One is somatostatin and octreotide. As I discussed, octreotide will around 50 mics of bolus, followed by 50 mics per hour infusion, and somatostatin will be around 250 mics of bolus, followed by 250 mics of infusion for around a period of 24 hours to around 4 days can be tried. And if you're going to manage it, the somatostatin and octreotide. And if you're going to use terlipressin, you need to consider the 2 milligrams IV bolus and can be titrated slowly over 4 hourly 1 milligrams, and once the hemorrhage is controlled, we need to manage accordingly. So before concluding about the management of, so what we have been discussed about regarding the management of HRS and regarding the management of refractory ascites and regarding the management of acute variceal bleed. So HRS AKI is always the first line of therapy. We need to consider whether the patient is for terlipressin and albumin, and second line if the patient is going for non-adrenaline and albumin, and the midodrine role is still not much of role in case of HRS AKI. But if the patient develops evidence of HRS type 2, the questionable issue is still there. And in HRS acute kidney disease, in type 2 HRS, there is a role of midodrine and terlipressin. And once a patient develops refractory ascites, midodrines can be considered. And if the patient is having PICD, paracentesis induced circulatory dysfunction, there is a role of terlipressin, midodrine, and with combination of albumin support can be done. And once a patient and if the patient develops UGA bleed, as I discussed right now, terli and somatostatin for paracentesis induced circulatory dysfunction, terli and midodrine and other drugs can be considered. So thanking you all. If there's any question, I'm ready to answer with you all. Thank you very much.
Dr. Arun, thank you so much for one of the most fiery and to the point presentation that I have heard, at least
Thank you,
in last
sir.
couple of months. It was amazing. The kind of clarity that you brought in your presentation and the kind of studies, data, and supporting evidences that you have presented, it was amazing. I'm sure that all the audience who is viewing this webinar will definitely be benefited. So thank you so much, sir.
Thank you, sir.
I already have got a lot of comments regarding the wonderfulness of your presentation and the clarity of voice and the kind of energy that you were putting in while explaining. It was just amazing.
Thank you very much.
Sir, I'll come to you regarding some of the questions which our audiences has asked. And before doing that, let me request our audience to put their comments and the questions into the Q&A box so that I can capture all of them and as much as that we can have. Dr. Arun is with us. We are very delightful and he will be more than happy to answer all your questions. So a sincere request from my side. So let me come to you on the first question. It is quite an interesting question asked by someone unknown from Chennai only. That why hepatitis B is not curable, whereas hepatitis C can be cured within 24 weeks of treatment. Kindly clarify the difference.
Because of the multiple mutant and other things which is being happening in the field of hepatitis B, and the entire genetic process and the entire nature of natural history of hepatitis B will be entirely different. And that's why hepatitis C, the mutated ratio will be entirely different. And that's the main thing. The life cycle pathway will be entirely varying, and the replication cycle will be entirely varying. And that's the main area why hepatitis B, you need to try it and for a longer duration and rather than hepatitis C.
Sir, thank you so much for your elaborate answer on this, which was crisp at the same time quite elaborate as well. So the second question is, how is it? It's again, very interesting question. I don't know, that what somebody want to ask. From my side, that I will read out the question for you. How is it that almost all USG ABD scan of patient report as enlarged liver? And by food we eat, health supplementary tonics, DM drugs, hypertension drugs, etc., how it will lead to the cirrhosis of liver, or there is a malfunction of liver.
See, main thing, if the patient presents to you with enlarged liver, we need to ascertain the etiology for that, sir. So if the patient is being either because of alcohol or because of viral or any other thing, always you need to see if the patient is going for alcohol intake, there will be high possibility, more than 95 to 100% patient will be presenting to us with steatosis. So once a patient presents to us with steatosis, there is high possibility for the patient to go for fibrosis. then to cirrhosis, and finally to SCC to ensure. So if the patient is having steatosis, we need to measure the liver stiffness mainly by the fibroscan and do a baseline LFT, and based upon the stiffness measurement and other things, whether the patient deserves endoscopy, and whether the patient baseline LFT values, whether what about the ratio, what about the values of AST and ALT alteration, based upon all those things we need to take into account. Because isolated fatty liver doesn't mean the patient is normal. It can be having with other coexisting presentation like diabetes or thyroid or multiple other system involvement to be taken care into account. And the strong lifestyle modification is the most important thing to bring down all these major complications.
I hope that you have got your answer, because Dr. Arun was, I guess, very elaborate on this. The question to answer this question. Sir, there's a question about hepatitis A vaccination in relative to hepatitis A patient. So, you know, the person is
Hepatitis.
asking, yeah, he's asking how about hepatitis A vaccination in relative to hepatitis A patient.
Ideally, if you're going for hepatitis A vaccinations, ideally recommended if you're going to use based upon the age criteria. If the patient less than 12, we can go live attenuated vaccine strains of around 1 dose, sometimes even up to 2 doses can be tried in the management of hepatitis A viruses. But hepatitis A usually is self-limiting, but even then, hepatitis A and B viruses is having vaccine, and hepatitis A vaccine, 2 doses or 1 dose regimen is still being used.
Thank you so much, sir. Thank you once again. Somebody has asked from Chennai that is there any chances of fatty liver to develop cirrhosis?
High possibility of fatty liver to go for cirrhosis. That's what been the area of discussion. If the patient is going for NAFLD, as we have been initially considered, it's more common in the Western population, and now it has been described even in more parts of India. So apart from alcohol and B and C related pathology, even NAFLD is still be more considered to develop the patient for cirrhosis. That's why we need to do early fibrotic scan assessment, and the management process being involved in the treatment of resolution of the fatty liver, diet and lifestyle modifications, vitamin E support, another line as per the pivot study and multiple things. Nowadays, newer modalities of drugs, even to prevent NASH and other complications being available right now. So we need to take care of always, if the patient is having isolated fatty liver, there is high possibility and preponderance for the patient to go for cirrhosis.
Very, very elaborate answer, sir. I hope that you have got your answer, and thank you so much, Dr. Arun, for elaborating answers so much. Sir, there's a person from Chennai. He asked that how far you have given high dose of furosemide and spironolactone.
So in my experience, the dosage of furosemide and spironolactone, we are not been gone up to very high dose as per the guidelines of refractory acid is around 160 and 400 milligrams. Before, if you're going for such a high dose of furosemide, definitely the patient, there is high possibility there might be having underlying complications. The patient may be having renal issues. The patient may be having other symptoms. For that, we need to consider either the patient with albumin support or along with the paracentesis and large, continuous albumin and other things support has to be done if you are going rather than using only this furosemide and diuretics. Along with midodrine also can be considered.
Thank you so much, sir. Once again. There's a question in between the question. Let me remind once again the audience to put out their all doubts into the Q&A box session so that we can capture it all and ask Dr. Arun. So it has been asked that midodrine, how long it can be used in HRS?
That's what I've been discussed. If you are going to start the patient work, see, the HRS is almost the last complication, the final complication in the management. Once a patient develops severe decompensation, only the patient is going to end up in HRS. And there are so many pharmaceutical agents being coming with midodrine nowadays. If you are going for midodrine, the main thing, either there are multiple studies for 3 months, the multiple studies for 6 months being given. Only the cost issue is slightly high, but as the day goes further, definitely the cost is going to come down. Next to that, if you're going to use midodrine, we can use 3 months, 6 months, and some patients even for 1 year. And I had an experience of giving midodrine to a patient with 1 year in the management of refractory acid is overall before considering the patient for transplant, and now he's doing good after post-transplant issue in our center.
Thank you, sir. Thank you so much for sharing your experience, and even up to 1 year the doctor has given after liver transplantation, which is a great news for all of us. Sir, somebody has asked a small question that how to treat hyponatremia.
See, hyponatremia in asymptomatic patient in the background of cirrhosis, usually, unless and otherwise, if the patient doesn't comes with if the patient's serum sodium, if it is not going to be less than 125, no need to treat hyponatremia because it's a dilution event. Only when the patient is going for very less of a sodium, like for example, if your patient presents to us with less than 110, but the ideal thing, you are not supposed to use a volume expansion agent like the 3% saline and all, you are not supposed to use much. And main thing, you can use albumin and salt restriction along with, we can consider midodrine in the management of severe hyponatremia process.
Thanks, sir. Thank you so much. There is a audience of ours who has asked a question about the diagnosis of paracentesis-induced circulatory dysfunction, which is PICD. I'm sure that you have covered that in your presentation.
That's what I say. If you're going to suspect PICD, it is mainly after the post large volume paracentesis. If you're going to tap for more than 5 liters, and if you want to suspect PICD, there is one better lab criteria can be taken into account if it is by plasma renin activity measurement. If you're going to measure the PRA, if it is going to be more than 4 nanograms, then there is high possibility for the patient to develop PICD. But once the patient develops PICD, we should always remember that to prevent the post PICD, hemoperitoneum, and other complications should not set in. For that, we need to tackle in a proper way.
Perfectly all right, sir. Thank you so much. I'm sure that you have got your response about the diagnosis of PICD. Sir, our viewer has asked about the role of antifungal in the management of refractory ascites.
We have been tried in our center once the role of antifungal, but initially you should not suspect any antifungal therapy. But if you are going to suspect as SBP, the common things you always need to look for the battle focus, and even some fungal ascites, fungal culture also has been proven, but it is very, very uncommon presentation. Always you need to treat the first thing in the management of start the first line antibiotic, take care of the diuretics, that is the patient to a low salt diet, and consider midodrine another thing. And once the patient develops fungal and it has been a proven one, then we can consider, but usually it is uncommonly, it's one of the uncommon presentation to happen in the management of cirrhosis.
Thanks, sir. Thank you so much. So fungal infection is very uncommon in this situation, so please have a note of it. Somebody has asked a very direct question. He said when not to use tolvaptan.
Tolvaptan, if the patient is having renal dysfunction, ideally tolvaptan is not to be considered. But as we are going to consider, the tolvaptan dose approximately 120 milligrams per day can be tried. But if the patient is having renal dysfunction, or if the patient is having evidence of NCAF or other things, tolvaptan should not be considered for that kind of patients.
Thanks, sir. Thank you so much. Let me tell you, Dr. Arun, that many people have congratulated you on a Q&A box and said that the presentation was amazing and awesome.
Thank you, sir. Any other questions to share, sir?
Sir, we have one or two questions. That is it safe to use midodrine for long term? You have already answered that it can be used up to 1 year. You have already experienced this in one of your patients.
But there are studies being tried even up to 2 years.
Okay, sir. What is the maximum dose and the duration we can use for midodrine? You have just answered, I guess, but you can repeat.
Yes, the maximum dose we can go up to 17.5, but the beneficial effect is very low. But what is the thing? We have been tried. I have been tried in our center. So we'll be giving by 5 milligrams followed by 7.5. We usually titrate the dose only by 5 to 7.5, and sometimes if needed, we will go up to 10 milligrams of midodrine support.
How long also, sir? Duration?
So we'll be considering for a period of around 6 months, and before that the patient should not be anticipating with other complications. The patient should be considered for early transplantation. So usually we'll be considering up to a period of 6 months, but when you're starting on midodrine, the cost issues has to be taken into account strongly.
Thank you, sir. Thank you so much. Sir, is there any dermatological changes associated with NFLD?
There are high possibility for the dermatological changes to happen because once the patients develop non-alcoholic fatty liver disease, as the initial presentation, the patient once the patient develops going for cirrhosis, there is high possibility for sarcopenia, there is high possibility for moon-like faces and other things. Initial presentation and the skin changes, loss of elasticity, and other things can happen as a dermatological presentation also. And that are multiple complications can happen, and acanthosis can develop, multiple dermatology issues can develop, the patient is going to develop NAFLD, cirrhosis, and other complications.
Thank you so much, sir. There is somebody who has asked, not specified as such, but he has asked what are the main side effects of the newer drugs, though they have not mentioned what are the newer drugs that they have asked for.
Suppose in case we are going to consider chalipressine, the main side effects will be, it can produce arrhythmias to some extent, and it can predispose to diarrhea. But this kind of the side effects can be happening, but it will be more in case of norepinephrine and other drugs. But midodrine usually that is also can predispose to headache and other complications. And so when you're going to use this kind of drugs, and also you should remember, if you're going to use midodrine, it will be affecting the hypertension and other process. So midodrine is also one of the drug for postural orthostatic tachycardia. So if you're going to use midodrine and other things, always you need to look for the rational cardiac status. Everything has to be taken into account before starting the patient management.
Sir, thank you. Thank you again for your very elaborate response. How much increase in the MAP that you can expect when you're using midodrine, sir?
That's what the target MAP actually mean artery pressure is nothing but if you're going to calculate the diastolic BP with 1/3 of the pulse pressure. That's the target map. So if you're going, so the you need to your map should be in the range of 60 to 100. So either it should not go down or either it should not be going very high. And based upon that, your management. Our intention when you're going to use midodrine and other things, our target should be around 5 to 10 millimeter of mercury above the baseline level.
Thank you, sir. Thank you so much. I'm sure that our viewer would have definitely got his answer. I have come across to last two questions, sir. So there's a second last question to you. What are the incidences of hepatoma in cirrhosis, in liver cirrhosis?
So incidence of hepatoma and liver cirrhosis will be around 1 to 4% that the population can develop, and this ratio can be varied based upon the etiology, based upon alcohol or hepatitis B or C, or based upon NAFLD. But outline, it will be usually less than 5% if the patient is having cirrhosis and other presentation for a longer duration of time.
Thank you, sir. So last question for this session. What is the role of aflatoxin in hepatoma?
Aflatoxin is one of the potential trigger. That's one of the co-carcinogen to be considered in the management in the predisposing factor of hepatocellular carcinoma. It can be considered as a co-carcinogen like alcohol, because we all know that the major things will be chronic hepatitis B and C. But apart from alcohol, even aflatoxin, because of the metabolite, octopamine, and other things, can also be predisposing to this hepatoma and other complications.
Sir, thank you so much. I request you, sir, for few one or two or three take-home messages for our viewers, which will be very beneficial, I'm sure, for all of them.
So, to conclude, the take-home messages will be: if you are going to manage a patient with ascites, the main step will be adherence of salt has to be ensured. If the patient is going to be adhered to the salt, we need to calculate the urinary sodium potassium ratio has to be more than 1, and that has to be enhanced properly if you are going to manage the patient with ascites, and titrate the dose of diuretic based upon the clinical response. And after that, whether the patient is strictly entering into the criteria for refractory ascites has to be ascertained properly. And before concluding, we need to look for the long-term complications. And any patient, if you're going to put on any therapy, if the patient is going to worsen, that always you need to suspect. Suppose if the patient is having decompensated ascites, if you're going to put the patient on any other medications, and rapidly if the patient is worsening of renal dysfunction, always you need to suspect a infective pathology or infective source to be identified. So even say SBP doesn't mean that spontaneous bacterial peritonitis or urosepsis or multiple things to be taken into account. Even then, if there is no active clinical presentation, sometimes without active clinical presentation, these kind of events can always be there. So to conclude, always screen early and detect the complications early, and refer the patient for transplant to save the liver. And regarding this World Hepatitis Day, which is going to march soon in the date of 28th of July, and our team is nothing but hepatitis free future in 2020. Our target, our WHO target should be India should be hepatitis B free, hepatitis B free nation by at least by 2030 has to be ensured.
Sir, thank you so much for a very hopeful and your kind words for all the hepatitis patients. On behalf of Mylan, sir, we would like to thank you for your
Thank you.
very, very energetic presentation, very crisp, to the point, knowledgeable, and I can add lot many adjectives to your presentation.
Thank you.
I'm also thankful to the audience who were participative, asked so many questions, and I'm sure that this session, this webinar conducted by Mylan Pharmaceuticals and with the help of Dr. Arun is definitely beneficial for all of you. We look forward for more collaborations and the programs in future. Till then, thank you so much. Be safe, be strong, be healthy.
Thanking you one and all.
Thank you, sir.